Okay, we'll give it a shot. So for those of you joining us virtually, if you cannot hear us, just let us know, but we're going to get the meeting started. So good afternoon, everyone. Thank you for coming. I'm Lee Jackson, and I'm a Senior Program Officer here at the National Academies of Sciences, Engineering, and Medicine's Board on Health Sciences Policy. And on behalf of the National Academies, I welcome you to our fourth public meeting, public information gathering session for the Committee on the Clinical Utility of Treating Patients with Compounded Bioidentical Hormone Replacement Therapy. The National Academies has convened an esteemed committee of experts to undertake the important task of assessing the clinical utility of treating patients with compounded BHRT drug products, including a review of the historical and current use and the available evidence on product safety and effectiveness. The committee's charge is described in more detail in their statement of tasks, which is posted online at the Academy's webpage. So at this time, I'll turn things over to the committee chair, Dr. Donald Madison.
Let me turn on my microphone and add my welcome to all of you as well following these. As she mentioned, this is the fourth public meeting. We've been very, very interested in reaching out and gathering input from multiple stakeholders around the United States. And also to remind you all that there are 200 roughly registrants.
That link that Dr. Donovich was going to testify at for gathering bioidentical.
So if you're on Zoom, can you mute your microphone, please?
NASCM National.
Was he on there?
No.
So this is a community as well, and online there are approximately 200 individuals. Thanks, Lee. And I'd like to welcome everyone. As chair of the committee and on behalf of its members, I'd like to thank our study sponsor, the Food and Drug Administration, for their support of this important study. I'd also like to thank the guests and guest speakers and individual of the public who are joining us today. Today we have 6 invited speakers, Dr. Thomas Menningham, Rona Hauser, Gary Donovitz, Pamela Smith, Peter Koshland, and Gina Bestman, to share evidence and their expert opinions on topics related to the clinical utility, use, safety, and effectiveness of compounded biomedical hormones and other comparable products. After each presentation, there'll be a short question and answer period for the committee, and then if there is sufficient time, we'll open it up for a small number of questions from others. I'd just like to remind you all that this is an open on-the-record session. It's not a news conference. We won't be able to field all questions from the public or the press. If individuals on Zoom have questions for the committee or the invited speakers, please send your questions to the study's email address, bhrt@nas.edu. We'll do our best to include those as we can, given our limited time. If there are any reporters who are present or online who would like to speak with members of the committee, they're asked to speak with the senior staff during the breaks, or again, send us that request at the bhrt@nas.edu. The committee members, while we've spent a fair amount of time working through the literature and debating and discussing the topics, have not come to any decisions yet. We're still in the information gathering mode, and that's the goal of this session. This is an information gathering session. The committee is in the process of assembling materials that will ultimately be examined and discussed in the course of making its findings and conclusions and recommendations. I'd like to recommend that you all be extremely mindful of the fact that the committee has made no conclusions to date. Comments made by individuals, including members of the committee, should not be interpreted as a position of the committee or of the academies. In addition, committee members typically ask probing questions in these information gathering sessions, which may not be indicative of their personal views. We will, as a committee, deliberate thoroughly before writing the committee's final draft report. However, once the draft report is written, it goes through a rigorous review process by multiple experts who are anonymous to the committee. The committee must then respond to this review with appropriate revisions that adequately satisfy the Academy's Report Review Committee and the National Academy's president before it's considered an official Academy report. And with that, I'll turn to the Vice Chair, Dr. Ruth Parker, to provide an overview of the events this afternoon.
Good afternoon, and thanks again to everyone for joining us. We appreciate your time and look forward to your comments. I echo those of Lee and Don and appreciate your being here. As Don mentioned, we've invited 6 speakers that'll be joining us this afternoon. The first panel will have 2 leaders in the pharmacy community, Dr. Thomas Minigan, who's Executive Vice President and CEO of the American Pharmacists Association, and Dr. Rona Hauser, Vice President of Policy and Government Affairs at the National Community Pharmacists Association. These 2 speakers have been invited to provide short remarks that outline the comments made in their recently submitted letter to the committee. That will be followed by the second panel where we will hear from 2 medical providers, Dr. Gary Donovitz, founder of Biote Medical, LLC, and Dr. Pamela Smith, founder and director of the Center for Personalized Medicine. We hope that these 2 speakers will address the committee's research questions related to the clinician's education, prescribing practices, and clinical use of compounded BHRT. And our third panel will hear from 2 compounding pharmacists, Dr. Peter Koshland, CEO of Koshland Pharmacy, and Dr. Gina Besteman. I'm sorry if I missed. Is that okay? Got it. Thank you. Director of Compounding and Dispensing at the Women's International Pharmacy. We hope that these 2 speakers will address the committee's research questions related to pharmacy education, formulation practices, safety, and quality of compounded BHRT. Again, we appreciate all of our speakers taking time to join us today, and we look forward to hearing more about their work and experience prescribing and dispensing compounded medications. With that, I'll turn things over to our first speaker, Dr. Thomas Minigan from the American Pharmacists Association. Thank you.
Thank you very much, Chair Madison, Vice Chair Parker, and members of the committee of the National Academies of Science, Engineering, and Medicine for the invitation today. We especially appreciate your response to the American Pharmacists Association request with our colleagues, the National Community Pharmacy Association, and the International Academy of Compounding Pharmacists to provide a forum for physician and compounding pharmacist practitioners to testify on the importance of compounded bioidentical hormone replacement therapy, or CBHRT. I'm Tom Minigan, the American Pharmacists Association Executive Vice President and CEO. APHA is the oldest, largest, and most diverse pharmacy organization in the U.S., representing more than 60,000 pharmacists. Our Academy of Pharmacy Practice and Management Compounding Pharmacy Special Interest Group, or SIG, consists of more than 5,000 members committed to meeting the individual needs of the patients whom they serve. APHA promotes patient access and coverage for pharmacist quality patient care services. Our members contribute to health in a wide variety of settings, including physician offices, specialty and community pharmacies, health systems, senior care facilities, industry, and academia. As an organization, we continue to support both FDA's and this committee's efforts to ensure drug quality and security. We support the provision of safe and effective medicines, including compounded medications, which is of paramount importance to our members. I was formerly a practicing community home infusion and specialty pharmacy owner for over 25 years. I understand firsthand that compounding is an important part of pharmacy practice because it permits patients with unique medical needs to access prescribed, patient-specific, personalized, vital medication preparations when commercially available products or dosage forms do not exist. As stated in our request, our organizations are pleased to assist the committee in assessing the body of knowledge, both experiential and scientific, that exists to inform the National Academy's conclusions about the clinical utility of compounded BHRT. I was pleased to hear the committee received, as a result of your solicitation, several offers from folks to speak to the committee from the practitioner members of the compounding community. I share the committee's enthusiasm and look forward to hearing the statements of today's compounding practitioners on the prescriber, pharmacist decision-making processes, formulation selection, testing standards and procedures, and professional education and training opportunities for prescribers and pharmacists. In particular, I'm pleased that APHA's immediate past compounding SIG coordinator, Gina Bestman, Director of Compounding and Dispensing at Women's International Pharmacy, will lend her expertise on patient-specific compounded BHRT to today's session. Lacking from many reports to date on compounded BHRT are the thousands of patients helped by these preparations. To help fill this gap, I know Gina will provide specific examples of patients who've relied on compounded BHRT. As stated in our request to the Academy, we know that double-blind, placebo-controlled clinical trials would be accepted as proof of clinical utility. Yet few such studies of compounded BHRT exist, and practitioners continue to prescribe BHRT for their patients. Accordingly, we urge the committee to consider broader definition of clinical utility in its research. This broader contemporary definition should include evidence of extensive experiential clinical use in addition to information available from evidence-based science, including observational cohort, systematic reviews, and meta-analysis studies. Non-sterile compounded BHRT has been commonly used for decades. Prescribers and patients utilize customized doses and dosage forms to utilize hormones normally present in the body. Currently, there are 17 FDA-approved bioidentical hormone products. Yet, the needs of a small percentage of the population are not met by mass-produced, mass-manufactured FDA-approved drugs. Decisions to prescribe and compound BHRT are based on many considerations. These considerations include patient compliance, which may be hampered by palatability or tactile issues, dosage form acceptance and convenience, specialized doses that adjust dosing to optimize clinical outcomes or minimize adverse events, and intolerance or allergies to excipients. Compounding is the creation of a pharmaceutical preparation by a licensed pharmacist to meet the unique needs of an individual patient, either human or animal, when commercially available drug product does not meet those needs. The USP, U.S. Pharmacopoeia or USP, formally defines compounding as the preparation, mixing, assembling, altering, packaging, and labeling of a drug, drug delivery device, or device in accordance with the licensed practitioner's prescription, medication order, or initiative based on the practitioner, patient, pharmacist, compounder relationship in the course of professional practice. There are many examples where compounded preparations are necessary. A patient may not be able to tolerate the dosage form or strength of a commercially available drug product. Said another way, the exact preparation needed may not be commercially available, or a patient may require a drug that is temporarily unavailable, in short supply, or discontinued. Following are a few examples of how compounding pharmacists can customize medications based upon a prescriber's prescription order to meet an individual patient's needs. Customize strength or dosage. Flavor a medication to make it more palatable for a child or pet. Reformulate the drug to exclude an unwanted, non-essential ingredient such as lactose, gluten, or a dye to which the patient may be allergic or intolerant. Change the dosage form of the medication for patients who, for example, have difficulty swallowing, or experience stomach upset when taking oral medications. Customized dosage forms may include flavored liquids, topical creams, transdermal gels, suppositories, or other dosage forms suitable for patients' unique needs. Under the law, compounding does not include preparing copies of commercially available drug products. I'd like to also address today's session objectives to discuss the professional education, training, and guidance for clinicians in the area of compounded products and their use. Pharmacists receive doctoral level education and training, with some pharmacists furthering their training to become specialists with accreditation and board certification. Pharmacy Compounding Accreditation is available as a service of the Pharmacy Compounding Accreditation Board, or PCAB, which we helped found with other organizations here today. This accreditation process for pharmacy practices assess the non-sterile and sterile pharmacy compounding process as defined by a specific set of standards. These standards concentrate on the quality and consistency of medication preparation. The Accreditation Council for Pharmacy Education, or ACPE, is recognized by the U.S. Department of Education for the accreditation within the United States of professional degree programs in pharmacy leading to the degree of Doctor of Pharmacy. ACPE's academic standards for pharmacist training requires compounding as a core competency for student pharmacists, as central content area to a contemporary, high-quality pharmacy education incorporated at an appropriate breadth and depth in the required didactic Doctor of Pharmacy curriculum, end quote. ACPE requires training to achieve the following competencies. Under extemporaneous compounding, preparation of sterile and non-sterile prescriptions which are pharmaceutically accurate regarding drug product and dose, free from contamination, and appropriately formulated for safe and effective patient use. Analysis of the scientific principles and quality standards upon which these compounding requirements are based. And under pharmaceutical calculations, mastery of mathematical skills required to accurately prepare prescriptions, including extemporaneously compounded dosage forms that are therapeutically sound and safe for patient use. Calculation of patient-specific nutritional and drug dosing delivery requirements are necessary. In conclusion, and as stated in our request, we believe the committee will benefit from the expertise of your invited presenters today. These are actual practitioners, both physicians and compounding pharmacists, with compounded BHRT expertise and experience to lead the National Academy's final study. Our organizations appreciate the National Academy's distinguished record of public service. We ask you to protect patient access to prescribed medications as the committee works to complete this FDA commissioned study, clinical utility of treating patients with compounded bioidentical hormone replacement therapy. Pharmacists stand ready to help the committee understand both compounding, including BHRT, and the positive role that compounding pharmacists can and do play in meeting the healthcare needs of our patients and optimizing their customized therapies. Dispensing of compounded preparations offers pharmacists the opportunity to counsel patients on the most effective use of their therapy. The pharmacist can explain that the particular medication has been prepared just for them and describe any specific instructions for effective use. Thank you for holding today's public session to better understand how patient needs are met when personalized compounded preparations are available. Thank you.
Thank you. Are there questions from the members of the committee? While you're thinking, let me ask you a couple of questions, if I may. Can you describe how the criteria for accreditation with respect to compounding has evolved over the past several decades? What changes have occurred, and how does that either strengthen or put at jeopardy pharmacy schools' accreditation?
Mm-hmm. So let's talk first about pharmacy school accreditation, and then I'll touch on standards. With regard to pharmacy school accreditation, these are stakeholder-based standards that ACPE puts together with various stakeholders in pharmacy, related to the educational requirements. So all schools of pharmacy in the U.S. are accredited, or they don't graduate pharmacy students. ACPE requires these particular skills that I described to you of all the graduates of pharmacy schools. So pharmacy schools teach extemporaneous compounding. They teach the related calculations associated with getting the dosing right. I would say that the technology used in compounding has evolved, and so the teaching standards have evolved to meet that. If you look in compounding labs today in schools of pharmacy, you'll find fairly modern equipment that's used to help train pharmacy students into practice. With regard to standards, the standards were developed a number of years ago, but more recently than accreditation of pharmacy schools. I'm guessing that PCAB has been around roughly 20 years, maybe a little less, and maybe more like 15. And in that time, I was directly involved as a board member of PCAB early in my tenure at APHA, but then PCAB was spun off and is now a product, if you will, of ACHC, another accrediting organization. So I've not had any direct relationship with the evolution over the last 4 or 5 years of the compounding standards, but they're certainly available for your reference.
Could you go back to the USP definition? Could you go back to the USP definition of compounding?
Sure.
And are all of the elements of that definition a part of your advocacy for strengthening compounding as it relates to bioidentical hormone products?
I would say it's fair to say they are, yes.
And one of those is labeling?
Mm-hmm.
And how do you advance labeling in compounded preparations?
I'm not a specific expert on labeling. You know, there was a time I could name all the elements of labeling for you. I'm not expert at that today. I think other people would be better equipped to answer that.
Okay, thanks.
Mm-hmm.
Questions?
Could you, what is ACHA? You mentioned it, just the acronym.
ACHC.
Okay, what is that?
American Council for ACHC, American. I'm blanking on the acronym. I can healthcare accreditation. Yeah. Okay.
I'm sorry.
I can.
Does somebody know it?
I don't recall.
So I just want to understand. So just to get the history straight, so
they're a large accrediting body that accredit a number of different healthcare.
Not just compounding pharmacy.
Much broader than compounding pharmacy.
So to your understanding, so your organization was part of the group. There were several that initially founded.
Yes.
Right. That
yes.
founded what's it called?
PCAB, Pharmacy
PCAB.
Compounding Accreditation Board.
Okay.
That included USP and NCPA and other organizations.
And can you give me a sense, so you all founded this like 15 years ago.
More or less.
And
yeah.
over the course of that, can you give me some idea of how many pharmacists were accredited through this? And as I understand it, you would accredit yourself as an individual pharmacist, not as a pharmacy. So the pharmacy.
Right.
So if you can give us some idea of like how many pharmacies were accredited by that organization over however, and then when the transition to ACHC happened, and any information about how many pharmacies are currently accredited, A's and B's, and sort of just, you know, what's the history there, and then what does that actually mean? And has what it means to be accredited evolved or changed, or how has it evolved and changed over the last 15 years?
Okay.
Thank you.
So I'll give you my oral answer. Be glad to follow up with perhaps what may end up being a little more accurate written explanation, and then I'll lean to my colleague to the right who was also involved from NCPA. But in general terms, Pharmacy Compounding Accreditation Board was founded by a group of pharmacy organizations to ensure high quality in compounding practices. USP was part of that group at the same time. There came and at the time that it was handed off to ACHE, the number of compounding pharmacies accredited by ACHE was in the hundreds. It was not massive, it was in the hundreds. I can't comment today about how many pharmacies are accredited by ACHE as compounding pharmacies, but I'm sure that information is available, and I'm happy to help you get it.
I have it in my statement. I'll talk about it.
Great, and you'll also tell us a little bit about what that actually means and like how do you get accredited and what that means. Great, okay. And it was only for pharmacies. It was not for individuals, say physicians who compound or anything like that.
No,
this had nothing to do with that. This was just merely pharmacies who would compound for their accreditation.
I'm unaware of any physician practices that pursued accreditation.
Okay.
Jose.
Tom, thank you for the presentation. One question that I have is, APHA has written in the past position papers and statements about compounding, and my question to you is, what is the current view of APHA in terms of what are the current challenges of the practice of compounding, and what are the areas or elements that that really need attention and potential changes and refinement in the way that the practice of compounding takes place, given some of the current issues associated with it?
I'll try to answer that without going down some areas that have yet to be resolved. There are certainly questions that USP has raised, for example, about products themselves that I think is sort of outside the scope of this today. I'm trying to think any other issues. Clearly, drug quality and security. There will be issues that arise there. That how do you maintain pedigree on compounded products, for example, but I think those are resolvable questions. Yeah.
Other questions from the committee?
Thank you.
Okay, great. Good afternoon. Thank you for the opportunity to present. We are very acronym heavy in pharmacy. So Tom and I were looking at each other a little bit on ACHC, but it's Accreditation Commission for Healthcare. And there were 8 organizations, including the 2 represented right here, that came together. And as Tom mentioned, USP was part of that group. The National Association of Boards of Pharmacy were part of that group. They came together in 2007 to form PCAB. And then it became part of ACHC in 2014. And I'll get into the number of accredited pharmacies in my statement.
Maybe I'll jump in with a little light comment here.
Sure.
And just say that this is very much an ARE here, which is an acronym-rich environment.
Thank you. So we feel at home. Okay. It's a good one. I'll use that now, Liz. Do it. The National Community Pharmacists Association represents America's community pharmacists, including 22,000 independent community pharmacies. According to the 2019 NCPA Digest, 56% of NCPA's members provide compounding services, and that is a 6% decrease over the last 2 years. Together, NCPA members employ 250,000 individuals and provide pharmacy services to millions of patients every day. NCPA's members are small business owners who are among America's most accessible healthcare providers. We appreciate being asked to present today at this open session meeting on the clinical utility of compounded bioidentical hormone replacement therapy from the Pharmacy, Trade, and Professional Association perspective. As stated in our joint letter to NASEM with the American Pharmacists Association and the International Academy of Compounding Pharmacists, our initial concerns with this study related to the nomenclature and focus in NASEM's information gathering thus far. Regarding representation of expertise and perspectives, before today, NASEM had not had a public meeting to fully engage practicing physicians who prescribe or pharmacists who compound extensively CBHRT and hear their perspective and documented patient results they have achieved. Therefore, we sincerely appreciate today's meeting to allow physician and compounding pharmacist practitioners to present on the importance of CBHRT to their patients. In addition, to assist the committee, members of NCPA's Compounding Committee have submitted over 150 articles specific to compounded hormones, including a list of primary literature for each individual article. This data submission includes such information as inclusion and exclusion criteria, number of patients, primary outcome, clinical outcome, and delivery system utilized. CBHRT is needed because FDA products are not suited for everyone. The reality is that a market for CBHRT wouldn't exist without a call for it. In other words, if FDA products met all the clinical needs for patients, there wouldn't be a need for these compounds. Pharmacists serve as a support arm to assist the physician, and our members make recommendations for appropriate therapies. Compounding pharmacists proceed only with a valid prescription and oftentimes will work with physicians who refer patients. Dosing and approaches are patient-specific, and physicians may send a prescription for a consult related to compounded hormone therapies. NCPA members help their communities and patients with CBHRT products such as creams, capsules, and lozenges, which are used topically, orally, and vaginally. Related to compounding best practices, NCPA members have standard operating procedures and quality assurance and quality control protocols in place through in-house and third-party analytical assessments. Additionally, NCPA was integral in the founding of the Pharmacy Compounding Accreditation Board, or PCAB. There are currently approximately 672 PCAB-accredited compounding pharmacies. NCPA also offers a multitude of live and online continuing pharmaceutical education for our members and led an effort several years ago working with industry stakeholders to develop guidelines for quality sterile and non-sterile compounded preparations. These guidelines cover issues such as billing and payment of compounded preparations, appropriate education and marketing of compounded preparations, clinical judgment of therapy, and regulatory compliance and quality. I would like to conclude by thanking the National Academies of Sciences, Engineering, and Medicine and the committee for listening to the perspectives of community pharmacists. NCPA members are providing CBHRT under the approval of state boards of pharmacy and FDA. In order to maintain access to these therapies, NCPA urges NASEM to consider a broader, more contemporary definition of clinical utility in its research. NCPA is happy to continue assisting the committee with accessing the abundant body of knowledge, both experiential and scientific, that exists to inform NASEM's conclusions about the clinical utility of CBHRT. Thank you.
Thank you. While we're waiting for questions to bubble up from other committee members, can you describe a little bit the way that education for compounders has developed around MedWatch reports and FAERS reports?
Sure. As Tom mentioned, many of these things are taught in pharmacy schools, such as the systems FDA maintains that you just mentioned. Students learn about that in pharmacy school as part of their curriculum. That can be reinforced throughout their careers. I think Tom too mentioned that there is ACP specific requirements for compounding. The NAPLEX exam that pharmacists have to take to get their license also has compounding related questions, and some state boards also require on-hand compounding preparation at time of licensure. Related to the MedWatch, that is part of ongoing continuing education. Each state has different requirements about how pharmacists have to pursue and how many hours they have to maintain to maintain their license, how many hours of continuing pharmaceutical education. But many programs include information such as those databases, how to report to them, what pharmacists should do. As you can imagine, patients come into our member stores every day with questions, with examples, they need someone to talk to about problems they're having with their medications. And the pharmacist will assist oftentimes in submitting reports such as those so that they're appropriately housed. It's not a mandate to my knowledge, but it's definitely something that pharmacists are knowledgeable about and do that when they see the need.
Can you comment a little bit on the education that the members get with respect to conflicts of interest?
I would say we're happy to share some of our educational programming or examples of things that we've offered to our members. I would say with conflicts of interest, I'm happy to share with you these guidelines that I referenced in my statement. That's something that the industry, the provider side and the payer side came together a few years ago and worked really hard on this set of guidelines We know our industry, needs best practices, and, there's all kinds of different ways to go about that, but we decided as professional and trade associations to create those guidelines, and we do have information in there on conflicts of interest that I'm happy to share.
From your NCAPA members, do you have an accounting of the actual number of compounded bioidentical hormone products that exist?
I do not. We do not keep that kind of data. We just keep a membership database of how many members we have, and then we keep through our yearly digest how many provide compounding services. We don't get down into specifics about what type of compounds they're providing.
In terms of like unique prescriptions or formulations?
I don't have that information. I'm not sure if a group such as IQVIA would have that information. They do keep a lot of data on prescriptions dispensed.
Okay. When the occasion rises and you have to substitute an excipient in a prescription or change a formulation, what is the practice then to try to ensure that the integrity and bioavailability of the product is still maintained when there is a personalized decision on the compounding pharmacist?
Sure, and that's definitely a decision that's made between the compounding pharmacist and the prescriber. If anything has to be changed from the original valid prescription that's received by the pharmacy, pharmacists also work with the physicians on, the exact dosages, formulations, et cetera, and then pharmacists often work by formulations or recipes. I'll call them simply to say recipes, and there's, guidelines in place on how to substitute products that would be appropriate.
I'm more referring to the excipients part of the formula prescription. So that would be a discussion, really. I don't know if the physician would be the one that would rule out, or in an ingredient. And the concern is maybe that adding or deleting one of those ingredients can affect bioavailability, which in turn affects safety and efficacy.
Yeah, absolutely. And those discussions about excipients do occur. I feel it would be better for our physicians and our pharmacists to cover the those exact discussions, but they definitely occur.
Thank you.
So I just wanted to clarify and make sure I understood correctly. So they're currently, I think you said, they're currently 670 accredited. Is that right?
I think it was 672 exactly.
Okay, that are currently accredited, and that would be called by PCAB.
Yes.
Although that entity is now run by or owned by ACHA.
ACHC, correct.
ACHC, sorry. Okay, I want to make sure. So how many total pharmacies are there out there that compound? If there's 670 that are accredited.
Sure, and our data shows there's approximately right now in the United States approximately 22,000 independently owned community pharmacies, and our last digest showed that 56% of those compound. Now that runs the gamut from more simple, non-sterile compounding all the way up to more involved compounding, but those are the rough numbers that we keep as an organization.
About 10,000, okay, yeah.
If I could just add a PS to that. Many pharmacies that may report that they compound may compound a very limited number and volume of products. Accreditation is not a small feat. It's expensive, it's time consuming, and it covers the enterprise. So the fact that there are 600 to 700 pharmacies that are accredited might suggest that those are the busier of the thousands that compound and are more likely to pursue accreditation.
Okay. And then the other question, it's a follow-up to Adele's question. So I understand that you don't have any idea from the data that you all have about the volume of compounded BHRT formulations that are prescribed in any given year. If I understood correctly, you don't have any idea.
We don't, as an organization and association. I believe I've seen approximations. I can't remember from where. I'm sure we could help to get that information. But
that would actually, I would be interested in that. Like, who keeps that information? Like, we know the data sources for FDA-approved, formulations and how the products and how you get that. How would you go about finding out the volume and the volume by year of compounded BHRT? That would be really helpful. Who would you turn to find that information?
Well, I mentioned earlier IQVIA. They've always done a really good job of
Tell me again what that's
IQVIA. Talk about.
It used to be IMS.
Talk about.
Does IMS?
It's IMS plus quintile.
Yes,
Yeah.
thank you.
And does IMS keep track of the compounded?
I can't answer that specifically. I do know that they work with all the pharmacies through their pharmacy dispensing software. You know, pharmacy is very electronically connected, and each
Right.
time you're submitting a prescription through your system, there's a documentation of
Sure.
that. So there are means.
So you think perhaps IMS has it for the compounded?
Possibly, we could definitely
That would be
help you with that.
Okay. Thank you.
I know, like I said, in the back of my head, I have seen these general numbers somewhere in the past, but I can't remember right now.
I just wanted to follow up with Dr. Hauser's statement about a couple things. Does your organization conduct any research? You mentioned you develop policy and educational programs and best practices. So is there a research arm to this organization? Do you do surveys of best practices or?
There's not a research arm specifically. We do, you know, that we have been awarded grants over time where we're doing certain projects for the betterment of the industry. We do informal member surveys. We've definitely done informal member surveys on compounding, for example. I'm happy to share with you some of those results that we've conducted over time.
And to follow up on that, thank you. You talked about, did you say you were going to provide us with the documentation of patient results and outcomes? Maybe I missed that.
No, there are some members of, I'm the staff liaison to our NCPA compounding committee, and I know there has been submissions by members of that committee to this group of over 150 articles. So I know that data that's already been submitted to you all.
We have that.
Yes.
Okay.
Yes.
There was more. Okay. Thank you.
Thank you.
One of the committee members is online. Dr. Rubinow has a question. David? Is your mute on?
Shoot.
There you go.
Brilliant. Yeah, I was just, thank you, Don. I was just curious how adverse events, when they occur, are reported. How is that information organized and disseminated?
As I mentioned earlier, oftentimes the pharmacists are used to using the FDA MedWatch system. There's also some state boards. Perhaps, I don't know all the various requirements. Each state board, runs different rules and regulations. But I'd say the part that I would be most familiar with as a practitioner, is FDA. There's probably other avenues that the practitioners can discuss as well.
I'd say they're essentially the same they do for any adverse event, whether it's for a compounded product or not.
In the FDA regulations, the 503B pharmacies are required to submit adverse event reports. Do you all have any information on how many actually do that?
I would not. I'm under the impression there's approximately 50 outsourcing facilities, I believe. I'm not sure if that number still holds, but I would not have that information.
Okay. Other questions from the committee? If not, we'll turn to the second panel of presenters.
Thank you.
No.
So in the next panel, we welcome comments from Dr. Gary Donovitz and all of Biote Medical, founder and Biote Medical, and Dr. Pamela Smith, founder and director of the Center for Personalized Medicine. And we'll hear from them and then have a few moments at the end for questions from the committee and, if time permits, from others. Thank you. Welcome.
Do you have the advancer by you, the slide clicker? Okay, great.
There we go. I want to thank the committee for inviting me to speak today. Serendipitously, I was here back in May and was in the audience, and I did get to speak a little bit. But this time I think it'll be a little bit different and in a prepared way. So I want to thank, again, the opportunity to speak on bioidentical hormone replacement therapy and specifically compounded therapy. I want to really, because of the short time, cover 4 things. The Women's Health Initiative, not so much to review it, but to talk about its need and establishing the need for hormone replacement therapy in general. The hormone challenge, because our hormones, both men and women's, are going to decline, putting us all at risk for diseases, and I'll talk about that. I want to talk about replacing those hormones and what is the best way to replace those hormones, and then how do we deal with these declining hormones in men and women. And then I'll talk about my 30 years of experience and what I've seen and some research that's on the forefront. I hope to cover 4 main points. The first one is that research and clinical experience show that bioidentical hormones are indeed safe and effective, and the adverse events that I've seen in my past from hormone replacement therapies really have stemmed from synthetic hormones, not compounded bioidentical hormones. Compounds are necessary. I mean, hormones in and of themselves are idiosyncratic, meaning that bioidentical hormone replacement therapy or hormone optimization is really a form of personalized medicine. And so as such, it requires practitioners to look at the patient individually, optimize the hormones individually, and as such, practitioners need the flexibility afforded by compounded hormones versus their commercial counterparts, for which there's very few. Also, practitioner discretion and education. Again, because of this idiosyncratic nature of hormones, patients and their physicians rely on their practitioners for how do I optimize their hormones on an individual basis? How can I proactively address their declining hormone levels? And for me and for other practitioners, we really want the highest quality bioidentical hormones. That way, we're at the forefront of medicine as we prevent diseases versus cause diseases. And with the highest quality and individual dosing and precision medicine, we feel like we can do a great job in terms of prevention of other medical problems. I don't want to belabor my bio. You guys have read it. I'm a board-certified OBGYN. I've been in the hormone space for 30 years. I've been in the bioidentical space since the mid-90s. I've treated more than 20,000 patients with bioidentical hormones, and I'm an international lecturer and author on bioidentical hormones. I want to just go to the Women's Health Initiative to say that in 2002, and when I was invited to speak here today, I felt like, you know, this committee almost is in that same position of having the opportunity to save a generation, particularly of women, because in 2002, when this study came out and there was all these side effects from synthetic hormones, so many physicians actually quit prescribing synthetic hormones and hormones in general. And so as 80% of people quit taking their hormones, tens of thousands of women died because they weren't getting their hormones replaced. And I feel like we're there today where there is this pressure to get rid of compounded bioidentical hormones that could be the best in terms of individual care and could be the safest. And I hope to at least give you some idea of that today. And so maybe there is a big challenge for this committee and for all of us in terms of taking care of our patients. When you look at when hormones decline, most people think of hormones in terms of menopause or andropause. But for me, I found that testosterone in women actually starts decreasing in the mid-20s. And as such, if we don't treat the hormone deficiency of testosterone deficiency, these women are at risk for Alzheimer's disease, cardiovascular disease, the #1 killer for women, osteoporotic fractures, diabetes, and possibly breast cancer. I intend to show you some breast cancer data today, and I know you've already seen some also. On the male side, in the mid-30s, males typically start decreasing testosterone levels, and they'll lose probably 17% of their testosterone every decade thereafter. Again, if we don't replace their testosterone, they're at risk for Alzheimer's disease, cardiovascular disease, osteoporotic fractures, diabetes, and increased risk for more severe prostate cancers and sarcopenia or muscle loss. And in fact, if you look at multiple studies on all-cause mortality, almost all studies have shown all-cause mortality is higher if we don't fix the testosterone deficiency. Now, it's interesting in WHI, when you looked at their numbers, most of the people, or the median age was 63, and most of the people didn't have symptoms. So to have some sort of a test or some sort of a study where you're looking at, well, did the hormones work? Of course, there was no real significant symptoms in the majority of patients. So it really wasn't set up to be a study of do hormones work and should they be individualized. So there was a lot of problems with that. What I found is when hormones start falling, people start having symptoms, decreased energy, they don't sleep well, decreased sex drive and brain fog and mood swings and depression and all the things that you thought about, but you thought about them in older people. We see it in younger women and younger men. The problem is we're medicating these people with antidepressants and mood pills and memory pills and sleeping pills, which are really decreasing the quality of their life. We could actually improve the quality of life if we were to replace their hormones and did it in a safe way. So again, what we have to do, I don't know why that's in there twice, here we go. So what we need to do in terms of this personalized preventative medicine is figure out a way where we can give hormones safely with a lot less side effects and decrease osteoporosis, heart disease, cognitive decline and Alzheimer's, and breast cancer. Bioidentical hormones, by their very nature, are plant-derived, which is a good thing, versus animal-derived and some of the synthetic hormones, because your body has seen the bioidentical hormones, the receptors have seen the bioidentical hormones for their entire life. And so we would expect that those receptors would respond better to bioidentical hormones versus synthetic hormones that they haven't seen. And indeed, that's the case. So bioidentical hormones come with lower risk and better efficacy, and that's what I've seen over the past 30 years for sure. So because they are identical in structure and plant-based and have better efficacy and less side effects, that's what I've chosen to use in patients in terms of this preventative medicine. Synthetic hormones have a different chemical structure. Indeed, they do bind to those receptors, but those receptors are not set up for the same response using synthetic hormones, which typically most of the commercial products are made from those. Compound products allow the person doing hormone replacement therapy or hormone optimization to accurately dose the patient. That's the most important thing. The difference between a medicine and a poison is the dose. So we need to be better in terms of, or more accurate in terms of our dosing. We'd like to customize. What does the patient need? Which hormones? And by individualizing not just the hormones, but the dose, we can accomplish all of their specific needs. I'd like to use the highest quality because to me, the highest quality hormones and the safety factor associated with them, with the benefits that I've talked about, are going to have the patient stay on those hormones for a longer period of time. That's important because when you go back to WHI and Premarin and Prempro, 50% of people came off their hormones in the first year. Commercially, products are great for things that have a condition that's consistently the same across the big majority of the population. You have somebody who has seasonal allergies, it's easy to dose Claritin and those kinds of products. When you have people whose symptoms are completely different, whether it's menopause, premenopause, or andropause, how do we treat the individual symptoms? How do we get the hormones that they need and individualize it? We don't have commercially available products for that. So compounded products are the natural fit in terms of this idiosyncratic nature of hormones. They're the natural fit in terms of decreasing side effects and for having patients stay on their hormones for the longer period of time, which is where the benefits would be. I'd like to share with you my clinical experience, and to start with, I really don't understand why we haven't prevented osteoporosis. 1 in 7 women are going to get osteoporosis over the age of 50. If they get it, half of them will fracture sometime in their lifetime, and if they have a hip fracture, 30% will be dead in a year. That's a shame for a disease that's totally preventable, but it's not totally preventable using oral commercially available hormones. With testosterone, which is the bone builder, and in my experience using pellet therapy, we can increase BMD by 8% per year, more than 8% per year. That's 8 times better. I can reverse osteoporosis, I can prevent osteoporosis, and that would be better than having to treat osteoporosis with drugs that come with a whole host of side effects. Preventing heart disease ought to be our big focus. It's the number one killer for men and women. But if heart disease starts when we're young and testosterone deficiency occurs in our 20s as women and in our 30s as men, do we really want to wait until we're in menopause to decrease cardiovascular disease, and to decrease heart attacks when we can do it safely now? It's interesting when people say, well, synthetic hormones really no different than compounded bioidentical. It's just not true. Silverman did a study, looked at 17-beta-estradiol against conjugated estrogen, against synthetic hormones, synthetic estrogen, and synthetic progestin. 17-beta-estradiol was 3 standard deviations better. 3 standards, not even close. So if you want to reduce the risk of Alzheimer's disease, which is a huge drain on our economics of our healthcare system, as well as your family and your pocketbook, and as well as your family dynamics, it would behoove us to find a hormone that's the best hormone to decrease neurodegenerative conditions for sure. Let me catch up with my slides. So we know that testosterone decreases beta amyloid. We know that 17-beta-estradiol decreases beta amyloid. We know that both of them increase blood flow to the brain. Both decrease apoptosis in the brain. What we also know is that synthetic progestins have a dampening effect on that. Micronized progesterone, completely different. It also decreases beta amyloid in the brain. So again, bioidentical hormones were better than their synthetic counterparts. So I perform now 66,000 subcutaneous bioidentical hormone pellet procedures in more than 20,000 patients. 95% of my patients are staying on that therapy after the first round, and I've done so with less than 1% complications. Who do I treat? Premenopausal women with testosterone insufficiency, menopausal women with testosterone insufficiency, males with testosterone insufficiency, and breast cancer survivors who were told you could never take hormones because hormones cause breast cancer. But what if they were actually protective? I heard a question earlier about demographics, and so we actually did look at demographics in a large number of patients, and what we found was there was no household income that could only afford compounded bioidentical pellet therapy. It would span all really incomes. And the male patients were, again, between the ages of 35 and 70 for the most part, and female patients between 25 and their late 60s. So it's not just a way to treat people in the menopause and andropause, it's a way to treat people throughout their life. And where that has become important is we now are going to have an IRB study that's going to be published in the first quarter of next year. We looked at 1.2 million testosterone pellet procedures, and what we found, less than 1% complications and secondary reactions in 1.2 million procedures. IRB approved, and you'll see that in the first quarter. The other thing we've done, we have the largest study now ever done, 10-year prospective study using testosterone and estradiol in pellet form, prospectively in over 8,000 patients, with a 70% reduction in breast cancer, 70% compared to what they saw in the placebo group of WHI or in non-users of hormones. That is an amazing change for women's health and cannot be done with commercially available products. Within the last few months, a female consensus paper was published in a peer-reviewed journal. It was one committee that I was on. There was 12 people from around the world, and there was 9 resolutions. I'll just show you a few today. But the most important is that testosterone is not a male-exclusive hormone. In fact, this committee found that it was the most important hormone for women, no matter what decade of life. Without bioidentical testosterone, I can't treat my patients. Because if it's the most important hormone, there's no commercially available hormone to give them, and I have to start early in life. It's that important. It is breast protective, it is cardiac protective, and indeed it improves general health and quality of life. Those are the things that the North American Menopause Society says we ought to do. We ought to individualize the therapy. We ought to care about quality of life, and we ought to treat that. And in fact, again, testosterone insufficiency is going to be associated with increased risk in cardiovascular disease, the number one killer, and we can fix that. On the male side, Morgan Teller out of Harvard, he did his consensus report about 2 years ago, and his first resolution was that testosterone deficiency is a significant medical condition that affects everything. How are we going to individualize that therapy if we don't have the compounded drugs to do that? And compounded bioidentical testosterone is very good for preventing cardiovascular disease, reducing the severity of prostate cancer, as well as brain protection. So my hope today is that this committee will look and see that the research and clinical evidence alike have shown that compounded bioidentical hormones are safe and effective. Compounded bioidentical hormones are essential to treat my patients and the patients of the 4,300 practitioners that I'm associated with over 400,000 women under therapy. We need practitioners to be proactive about their patients' health. We need the practitioners to rely on a case-by-case basis of their judgment on how do they treat testosterone and estrogen deficiency and how do they optimize it in the safest way. So I thank you for your time. I hope I'm on time, and I'll be glad to answer any questions. Thank you.
Thanks, Jose.
Thank you for the presentation. The question that I have is you referred to hormones. You talked about the idiosyncratic nature of hormones, right?
Yes, sir.
Idiosyncrasy has different meanings to different people. Can you talk to me a little bit more as what you actually mean by the idiosyncratic nature of hormones?
Sure. So different hormones cause different symptoms in different people. And there is no threshold. It would be nice if I could tell you that at this level of testosterone, all women will experience fatigue or sleep problems or libido. But there is no normal threshold. There is no given threshold. So everybody's different. Every threshold is different. So it's a clinical syndrome. That's part of the problem is we're treating symptoms, not numbers. So we do take a history, we do get laboratory, but there's no question that testosterone insufficiency in the male, as in Morgenthaler's paper and our paper, both said the same thing. It's a clinical syndrome with no, and that's one of the, actually one of the consensus opinions, there was no given threshold. So because of that, we need individualized dosing for each patient and for each hormone.
So as a follow-up then, help me out here again. So is the idiosyncrasy a function of the hormone itself or individual variation, inter-individual variation in responses?
Right, it's the second one. The one you said, that was even better said. So it's a difference in the response of each patient because their receptors are different, their resistance. If you think about testosterone insufficiency, it's not just a deficiency of the hormone, there's also a resistant state, like there is with thyroid, like there is with insulin. It's very similar. So each patient will respond to a given dose of testosterone or estrogen for that matter, but they will respond differently. So you have to individualize the dose. It can't be a one-size-fits-all.
Okay, so then to get it clear, it's not that there are idiosyncrasies about the hormone, but inter-individual responses to a particular hormone, right?
That's correct. So
okay.
Our pellets, when we're making those pellets, are within 3%. When we look at the potency of the pellet, if someone writes for a 100 milligram pellet, let's just say, it will be within 3%. There's very little variation pellet over pellet, much less than in commercial products. And that's intentional so that when we dose a certain dose and we write a certain prescription, we get what we ask for, which again is a testament to the higher quality of the product that we're getting.
Could you describe a little bit the approach you take to assure the quality of your hormones from lot to lot?
Yes, sir. So what we do, we not only look at the testing that the 503B outsourcers use for our pellets, we independently lab test those pellets for purity, for potency, and for sterility. So those pellets are quarantined. They've looked at sterility studies. We use E-beam for our sterility. It's a dry process, but there's less than a 1 in a million chance those pellets are not sterile. So that's a good thing compared to the old days when they were autoclaved and other processes. Also, we look at purity and potency to make sure there's no impurities in there. In our pellets is only bioidentical testosterone with a little stearic acid or bioidentical estradiol with a little stearic acid. We don't put any of those other excipients into our pellets. And then again, we independently lab test those and we have those lot numbers. So if there ever is an adverse event, and we know about the adverse event, we can go right back to the lot number, right back to the independent lab test, and right back to the outsources testing of that pellet. Yes, sir.
And when you submit adverse event data, that's included the lot number and the characteristics of the product?
We don't submit. The FDA would rather the outsourcer submit, so our practitioners submit to whoever supplies their pellets for us, and then they report their adverse events and secondary responses to that outsourcer, who then reports it to the FDA.
Now, in Janet Woodcock's description of adverse event reports, did she indicate that there were something like 4,000 adverse events?
Right. It was really a misstatement for sure, and taken out of context. What I did about 6 years ago, now 7 years ago, when I first started training people in bioidentical hormones, and specifically pellet therapy, but other bioidentical methods, I created what I called a complication tracker. It was really an internal tracking mechanism so that we could see adverse events and we could see secondary responses. We got all of those into one basket. When Ms. Woodcock reported her thing, she showed 4,202 adverse events. That's not really true. More than 95% of those were secondary responses, meaning cellulitis or pellet extrusions. There was very few adverse events, and none of those adverse events actually met the criteria of the FDA: dangerous, hospitalized, death, and all of that. So we were looking more.
That's the definition for a serious adverse event.
Yes, sir. And so in terms of the adverse events, we actually, serious adverse events, and then we didn't have birth effects or serious disability from any of those. So it was more of a way for us to track. And the overall numbers, again, 4,202 were in over 1 million procedures. So it's way less than 1%. But the lion's share, like I said, more than 95% were secondary responses, cellulitis or pellet extrusions, broken out into male extrusions and female extrusions. And our male extrusions are half of what's been reported in the literature. The literature reports 8.5% pellet extrusions. Ours are 4%. Whether that's a testament to the pellets we use or the techniques or the training, I don't know. But I do know that it's half. In women, it's less than 1%. Now we have 1.3 million procedures with less than 1% secondary responses. We don't track the adversary. We have them reported to the 503B now, but that was simply a tracking so I could improve training and, if I needed to, improve the way the pellets are being made. But with less than 1% secondary reactions and adverse events in that many procedures, that's a pretty good testament to the quality of the pellets, the training, and the technique, I think.
Adele? And then I'll...
So so Adele, and then I think Robert has a question. Okay.
For estradiol, there are many approved products, transdermal products that are available. Why don't you use that rather than the pellet?
I do use transdermal products, and if they're on transdermal products and that's all that they need, I like transdermal products. So I like patches, I like creams a lot. However, if I'm going to use testosterone and there's no commercially available testosterone for women, it's easier for me to add the estrogen in as a pellet. If they'd rather stay on the transdermal, certainly that's the patient's decision. I can actually get better, more consistent levels with pellets, and that's been studied and reported, pellets against transdermal. So if I have the opportunity, again, I would use pellets. I don't really pellet anybody that's going to just get estrogen in the menopause because I do have transdermals and patches and commercially available things. So I would use that, or even compounded bioidentical creams over just pelleting somebody with estrogen. So I wouldn't do that. Yes, sir.
So that's my new verb for the day. To pellet someone. Thank you. Okay. So I think Robert, another committee member, is that right? Wherever we are, has a question. Robert?
Robert MacArthur has several questions. So to start off, does Dr. Donovitz order his pellets from the same 503B pharmacy or from different 503B pharmacies?
So we use more than one 503B pharmacy.
Okay. He also asked, does he feel that there's any difference between the pharmacies with regard to how the products are made or the doses that they deliver?
No, again, we independently lab test. We don't accept any pellets on the testosterone side that are not within 3% of the potency, and we don't accept any on the estrogen side, if we're going to use estrogen with the testosterone, that are not within 5% of the potency. And again, our pellets from both of our 503Bs are E-beam for sterility. So that's consistent with our dosing site. Otherwise, if we had multiple different kinds of pellets, it wouldn't work. So we feel like that formula's worked well for us.
Okay, and his final question, does your group test the pellets for rate of testosterone release over time, from days to weeks, or any time frame like that?
Right. So Jock and Hobel did a great study on dissolution. We have not specifically, because you don't get the pellets back because they're completely dissolved. So we don't look at that. What we do look at is peak serum testosterone levels, and we have certain target ranges for optimization on that. The dosing site, the way it's set now, has 4 million permutations. That dosing site is capable of getting people's hormones optimized in the first round 95% of the time. There are people, obviously, whose capillaries are bigger, blood flow is different, maybe they exercise less or more, but nonetheless, maybe their numbers were low or high. We simply adjust the dose in the second round. But even having done that, the adverse events or secondary reactions are low. But we do, in 5% of people, adjust, and we actually have a second round dosing site so that practitioners can dose based on side effects, whether it's acne or whatever, and they can get an accurate second round dose adjusted.
I had one question. If you could just specify the clinical indications for the use of testosterone in women across the life cycle and the duration of therapy based on your approach.
So our approach is when people present with the clinical syndrome, those were in that colored paper that you guys got, the symptoms, then we actually look at laboratory to see if their testosterone levels are low. If their testosterone levels are low, we also look at thyroid because we also optimize that at the same time. At that point, we would enter them into the dosing site. So demographics, other comorbidities, laboratory would go into how that patient is dosed. The frequency of the dosing is patient dependent in terms of how long do the pellets last. In women, it's usually 3 to 4 months. Could be 5, but it's usually 3 to 4. In men, it's usually 4 to 5 months. And that's based on dissolution studies, and it's been pretty consistent across the board. So women are going to get their subcutaneous pellet insertions. I won't say pellet anymore. About 3 times a year, and men usually twice a year.
So I probably didn't state it very clearly. Could you again state the clinical indications for using testosterone in women across the life cycle? Just start at the beginning, like women would be recommended to receive testosterone for the following indications, clinical indications, and then the duration of that treatment.
Correct. So women who present with joint pain.
What age? Starting at what age?
Typically, I don't treat women until the age of 25 and beyond.
Okay.
Most women are going to be 25 to 30 and then beyond. Joint pain, brain fog, fatigue, particularly afternoon fatigue, not sleeping well, weight gain, particularly across the midsection, decreased sex drive, depression. I don't know what else I missed in there. So those are the most common symptoms that we see, which is interesting because that goes all the way through the premenopause into menopause. Hot flashes is we actually looked at a symptom pie chart, kind of like the ones I showed you, and hot flashes were actually number 4. So fatigue, sleep, and libido were the top 3. So those are really the symptoms. Those symptoms will be treated lifelong, not because we want to just get rid of the symptoms, but people who have testosterone insufficiency, like I said before, increased risk for heart disease and Alzheimer's, as well as diabetes and everything, and osteoporotic fractures. So I'm starting early because BMD loss occurs in their 20s. So if I can get there early, I can totally prevent osteoporosis. If I want to decrease breast cancer, I need to get there early. If I want to reduce cardiovascular disease, I need to get there early and be consistent. Once we come off the hormones, they don't have the lifelong protection. So I'm not a believer in shortest time possible. I'm a believer, take your hormones for as long as you want to take your hormones, as long as you want to feel your best no matter what your age, because I am improving quality of life on the short run and preventing disease in the long run.
So one other question, based on 25 years of doing this, at least it sounds like from your clinical practice, do you have longitudinal cohort data that follows women on chronic testosterone therapy for 25 years and what happens?
We don't, because I didn't start using pellet therapy and really the testosterone until the 2005, 2006, and I do have longitudinal data there. And again, we report all of our adverse events. And so there is, again, low. So we're not seeing any long-term detriment to that. But again, I've only got 10 years, but that's pretty good, of data. We are doing a study starting in January on the 400,000 patients and on the go forward, where we're actually looking at the health questionnaires, both male and female, testosterone levels, as well as hemoglobin A1C and inflammatory markers, optimizing their hormones, seeing what happens to their insulin resistance, their inflammatory markers, testosterone levels year over year, and I'll have that data in a year.
So let's go on to our next speaker, and then we'll have a little bit of time after that as well. So Dr. Smith?
Hi, I'm Dr. Pamela Smith. I teach at the Morsani College of Medicine at the University of South Florida, and I specialize in natural hormones. How did I come upon doing this is really actually a fascinating question. I was extremely happy being an ER doc in a level 1 trauma center in Detroit. I really loved being an ER doc until one day I could not sleep. And after going to 11 doctors, and they told me to take a sleeping pill, I said, well, I'm used to going from night to day to night shift. Why? And I went to a conference, and I found out that perhaps my hormones were not balanced. I had a tubal ligation. 40% of women who've had tubal ligations do have some hormonal changes. And I did a test and found out I had no progesterone. I'm not a very big person. I wear a size 4. I'm 5'2". I weigh about 127 pounds. I believe in traditional medicine very, very much. Are there natural hormones made by the FDA? They are. Do I use them? I do. There is estrogen as a patch. It is estradiol. That is a bioidentical hormone. Does the FDA make an approved or actually a bioidentical progesterone? They do. It's called prometrium. But the dose is not always perfect for every single patient. And for me, I needed 270 milligrams of progesterone. There isn't a dose that comes close to that. And the reason I needed that is that I was very estrogen dominant. I will probably be the most conservative speaker that will ever be here on natural hormones. In the last 12 months, I have taught on 4 continents. If you ask me where I was 10 days ago, I was teaching in Tokyo. Where will I be Saturday? I'll be teaching in London. So does it matter if you do this right? Of course it does. But it's all about balance, and it's all about starting low and going slow. So what education do practitioners need? They really do need it in this field. So I went and got several additional degrees. My MPH behind my name is in environmental medicine and toxicology. So I do have a degree in toxicology. The other degree behind my name, beside being a physician, is an MS in metabolic and nutritional medicine from the Morsani College of Medicine at USF. And I also have a certification in advanced hormonal therapy. So I went and did my time so that I could do this in a proper manner that would be perfect for every patient. This is an era of personalized medicine, or what we at USF called precision medicine. It really is about the perfect dose for every single patient. Do some of my patients use FDA-approved patches of estradiol? They do. But we know from research that estriol, E3, is needed to help prevent breast cancer. So my patients need E3. So they can either use a patch that's FDA approved, and they can have a compounded E3 as a cream, or they can use what we call in compounding bias cream, 2 estrogens, which is E2 and E3 together. That is available, by the way, made by a pharmaceutical company in London. It's not available in the United States. And the studies are quite clear. I don't say that lightly. I have a very strong family history of breast cancer. My one grandmother, I never got to meet. She died of breast cancer before I was born. I have a cousin on that side that died of breast cancer as well. On the other side of my family, I had 2 aunts that got breast cancer. One died of breast cancer, the other survived. But a lot of that has to do with what dose do you use? How much estrogen does a woman make? At her peak level, at the age of 25, pre-luteal phase, meaning before she ovulates, she makes 365 micrograms of estradiol, baby dose. It does not take much. It's all about balance. Do you have to balance with progesterone? You do. How much progesterone does she make at peak stage, which is the luteal stage? She makes 25 milligrams. That's all she makes. 1/2 of women never lose testosterone in their life. I'm 65. I happen to be one of those women. I still have very normal testosterone. Too low is not good. It increases the patient's risk of heart disease, and it increases their risk of bone loss. Too much testosterone, interestingly, also increases the risk of heart disease and drives up blood sugar. So does every woman in the world need testosterone? No. It's about balance. We look at all the hormones. We look at the adrenal hormones, the hormones that are made in the adrenal glands, DHEA, and we also look at cortisol. Cortisol is the stress hormone. DHEA makes estrogen and testosterone. So they all have to balance. And who is not stressed in today's world? In our patients, we measure every single patient over and over and over again in the 27 years I've been doing this kind of medicine, and certainly this is my 41st year of practice. We look at adverse effects, but we don't get a lot in our practice because we use baby doses of hormones. Do hormones help prevent heart disease? Absolutely. The textbook that came out on Friday called Personalized and Precision Medicine Cardiovascular, and looking at the effects of it, I wrote the chapter on cardiovascular disease and hormones for both men and women. I've written the chapter when we look at pain control, and a pain control book that comes out in that textbook next year. Hormones help with pain control. But honestly, it's all about balance. If you don't get the balance correct, or you over or underdose that patient, then the patient can have side effects, and they will not have optimal health. I've written 10 books. One of them is on hormones. One of them is on memory. If there's one thing that I could do to maintain my memory in my entire life for myself and my patients, is to be hormonally balanced. Estrogen equals memory for women. Testosterone equals memory for men. It's just that simple. That's what the actual science shows. And that's what we look at. When a patient comes in to see us in our practice, this is what happens. They come in, they bring in their physical examination from their primary care physician. Yes, I'm a specialist, but everybody needs a primary care provider. So we have them do the physical. We make sure they have a primary care provider because some people don't take the time, and it's important that they do. We do look at overall health, but we measure the hormones when they come in 90 days. If they need hormones, then we prescribe them, and we measure them every 6 months thereafter, so that we always make sure they have the perfect balance. How many tests have I looked at? 20,000 saliva tests of my own practice, and another 10,000 of people, other practitioners that are in the program that I direct. So I've looked at 30,000 tests. Now you may say, why saliva? Is there a perfect way to measure hormones? There's probably not. But what the studies show is that if you put the hormone on the skin, and that is the most common way that estrogen and testosterone is prescribed worldwide, it does not show up in the serum or the blood. It will show up on saliva testing. Is it important to do urine testing? It is. It's important to look at the breakdown of the hormones. But when it comes to actual testing, you want the bioavailable, the amount that's available for the body to use, the free hormone. And that you can easily see with saliva testing for estrogen, progesterone, testosterone, DHEA, and cortisol. And when you look at the stress hormone cortisol, there are 6 medical trials in very conservative medical journals showing that the best way to look at cortisol, not for Addison's or Cushing's disease, but for hormonal balance, should be salivary testing. It is key that we have education for the pharmacist and education for the practitioners in how to prescribe properly. It is key that we look at adequate testing, and the patient is looked at over and over and over again, because cortisol is a very important hormone. How many of you in here, raise your hand, or out there, let us know, do you know what the hormone pregnenolone is? Raise your hand if you've heard that. That is your hormone of memory. Why am I bringing it up? We measure it, but pregnenolone makes estrogen, progesterone, testosterone, DHEA, and cortisol. If there's anybody in this room or by Skype, etc., is there anybody who's not stressed? I mean, I'm stressed. Everybody's stressed. This is a crazy world. We have to look at cortisol because it directly impacts pregnenolone. It's not just about, hi, here's your estrogen, or hi, here's your testosterone. This is how the body works. Pregnenolone comes from cholesterol. Yes, cholesterol is not evil. You have to have some. It holds the cell membranes together, and it makes pregnenolone. If the body is very stressed at any age, pregnenolone will directly make cortisol to keep the patient alive. You have to have cortisol to live. If you don't have it, you die in 7 days. So the body will preferentially make cortisol from pregnenolone, and the patient may not make estrogen, progesterone, testosterone, and DHEA, even if they're 25 due to stress. Does that necessarily mean I need to give them a hormone? No. How about if we work on their stress? How about if we have them do stress reduction techniques like prayer, meditation, Tai Chi, yoga, Qigong, exercise, massage, breathing techniques, acupunctures? There's actually medical trials in conservative medical journals on every single one of those techniques. How about if we work on stress? Everybody in the world doesn't need to have a hormone, but we need to measure and see. The number one reason that I personally give testosterone to a younger woman is oral contraceptives. When she takes birth control pills, sex hormone binding globulin goes up. When it does, more hormone is bound and it's not available for the body to use. So of course I have women in my practice that may be 30 years of age on testosterone, but it's due to the oral contraceptives. Why don't we personalize the approach for every single patient? It is the era of precision medicine. And what I'm in great fear of, and why I came here today, and I have to say, every patient that I told that I was coming here, they went, go for it. We want our hormones. There was not a single patient in our practice, and we have 4 offices in Michigan and 1 in Tampa, Florida, that negated the idea of us coming here. They feel fabulous, but we also are preventing disease. We're preventing bone loss. We're helping to prevent memory loss. We're helping to prevent heart disease. The studies are quite clear, and now we're even helping with pain control. Obviously, there's a big initiative on the opioid crisis. There are many things we can do, including helping the patient be hormonally balanced to help with her pain control. I used to have migraine headaches. I don't have them anymore. I'm very fortunate. I started having them when I was 16. What I found out later on is that my migraines were due to the estrogen dominance. Lots of estrogen, not enough progesterone. So when I started taking it, the migraines improved. Did I need a narcotic for my migraines? That would be absurd. How about if we looked at the cause of the problem? I still had an occasional migraine. The studies show that dopamine being low can cause migraine headaches. We can measure dopamine. It's a neurotransmitter like serotonin is. It's a urine test. Was my dopamine low? It was. I started taking something called L-theanine. I take it twice a day, and I've had no migraines for 5 years. And that's really why I'm here today. I'm here to represent my patient. My patients wanted me to be here today to really talk about precision medicine. And I really hope that this committee, and I really thank you for allowing me to speak, because the United States is the leader in healthcare at this time. And we want to stay the leader in the world. And we can do that by looking at the cause of the problem and individualize and customize care for every single patient. Does that sometimes mean FDA-approved drugs? Of course it does. Does that sometimes mean the patient needs a compound? Of course it does. We can now measure all of these things in the patient and provide a personalized precision medicine approach to every single patient. Thank you very much.
Thank you. So do we have questions from committee members, either who are here or on the phone?
I have one, actually two, but let me start with the first one. Both of you have talked about individualized, personalized, and/or precision medicine. Tell me a little bit about the clinical trials approaches that you would propose would improve our understanding of the role of compounded BHT as we go forward.
Well, certainly when you look at a personalized approach, if you look at my own family history, then you probably realize, if you're a scientist in this room, that I don't methylate well. I don't. That's a CH3 group being put where it belongs in the breakdown from cysteine through the body. People who don't methylate well have an increased risk in breast cancer. They have an increased risk in prostate cancer. So is there a methylation test? Yes. Have I done one? Yes. Do I break down estrogen well? No. And I haven't for my entire life, because I inherited a gene for poor estrogen breakdown. It's fixable in 100% of patients. So even though that I use estrogen, and even though that I take progesterone, am I worried about getting breast cancer? No, I'm not, because I went back and fixed that gene mutation that I have. The interesting thing about it is, yes, 1/2 of you in here have that mutation. So you may want to see a personalized medicine doc and have it checked. But you know what? Not everybody needs methylated vitamins. I take methotetrahydrofolate. If you take those vitamins and you don't need them, you have an increased risk in all cancers. So is it important that we look at methylation in every patient? Yes. Is it important when we look at it in relationship to estrogen supplementation in women? It's paramount that we get it right. Not only she has the right dose of estrogen, but she metabolizes or breaks down estrogen into the right forms.
So would that be an exclusionary or an inclusionary piece of data?
We measure estrogen breakdown in every single patient. Believe it or not, men do make estrogen. It's very important that they have estrogen for memory. It's very important they have estrogen for bone structure. 1/2 of men break down estrogen improperly. Those men have an increased risk in prostate cancer, perhaps breast as well. Breast cancer is on the rise in males. It's now 3% of breast cancer is in men. Again, it's a simple urine test. We can measure it in every patient. The science is here to fix it, whether they take hormones or not.
Right. So I agree with Pam a lot on the breakdown products. We, in fact, use a nutraceutical to actually make sure that breakdown product for estradiol goes through a pathway where DNA is repaired and we reduce breast cancer and prostate cancer. So I agree wholeheartedly on that, as well as the methylation. The precision medicine side is an easy thing to think about, because if people are stressed, that is also going to affect their thyroid that we didn't even get into today, but that's going to adversely affect how they feel, whether I optimize their estrogen, optimize their testosterone, do yoga, or whatever. So I'm a believer in lifestyle changes as well. I mean, my first cousin's Dean Ornish, so I can tell you, I know firsthand about exactly what she's talking about. But precision medicine with lifestyle changes alone isn't going to be as good as optimizing their hormones. And we just don't have the commercially available products that we need. And again, most of the commercially available products, as Pam said, are going to be dosing at much higher levels, whether it's patches or whatever. And so, yes, there's products available, but they either overdose or underdose. On the male side, the commercially available product that's out there, especially on testosterone pellets, underdoses, so at least under the FDA regulations. So that's a big problem. So if you're going to underdose, have you really prevented the more severe prostate cancers, and have you protected the heart? No, you haven't. And to Pam's point, if testosterone is the memory builder, have you done that? No, you haven't. So precision medicine involves looking at all the hormones, optimizing each individual hormone, as she said, and as we do, and by doing that, you can prevent so many of the diseases that are a huge drain on the system, because we're not doing anything for cardiovascular disease. In fact, there's no studies that show that statins and primary prevention work in women. So yes, lowering cholesterol, that's not it. It doesn't work in women, not near as well as hormone optimization, and they've had a 20-year run. And so for me, I think we need to look at, again, precision medicine and how do we reduce cardiovascular disease, because we've done a very poor job. But we feel like, looking at some of the numbers now, that we're starting to make inroads, because we can reduce plaque formation in the heart, we can reduce insulin resistance, and we can get to the root of the problem versus just putting a Band-Aid on it.
If you look at the American Endocrinology Society, the first thing that they suggest in their recommendations in a male that presents with insulin resistance or diabetes that's new is to go back and measure his testosterone and replace it. That is now first-line therapy by the American Endocrinology Society. That is not something that is considered off-label, et cetera. But remember, how much testosterone does a man actually make in a day? At his peak at age 25, he makes 4 to 8 milligrams. That's all. And it's very, very consistent. It's very different than women that have a 28-day thing going on. And I don't say that lightly. I have 5 daughters, so it's always been hormonally interesting in my house. God has blessed me with grandkids. So far, they're all boys. So it's been hormonally interesting since one of those is now 18 with boys as well. But it's all about balance. Our goal in both of us being here today is really to present the science to you, that the science is here to look at a personalized approach. Do I believe in compounding? I absolutely positively do. I would not be sitting in this chair without a compounding pharmacist. To make a long story short, when I was 28 or 25, I delivered my first baby and I infarcted off almost all of my ileum to the ileocecal valve, i.e., I lost part of my bowel. The annals of surgery, you can look up in 1978. It says youngest patient, 25 years of age with a volvulus. That is actually me. I spent 6 weeks in a hospital. And then later on in life, I kind of kept up with things until I got into my 60s, and I went into atrial fibrillation, an irregular heartbeat. Because I don't have a normal bowel structure and never will. You know what one of the treatments for AFib is? Magnesium. I can't absorb it because I don't have a normal bowel. You know what saved my life, literally? My compounding pharmacist. So if you go in my suitcase that's in my hotel room right now, you will see compounded magnesium, because I put it on my skin, it bypasses the bowel, and I had an ablation and haven't had AFib for 2 years. Without me being able to get it in, I probably wouldn't be here.
Lee? No, go ahead.
I just had a couple follow-up questions for you, Pamela, and thank you for your presentation. So I'll just start with one of them. So you said, it's all about balance, go low, start slow, yet you still see adverse effects similar to any other medication. Can you describe some of those adverse effects you see in your patients?
Actually, I have very few adverse effects at all because I really do start low, go slow. Progesterone is a very tricky hormone. You have to give it perfectly. If you give too little or too much, you can get the same symptoms: anxiety, irritability, insomnia, mood swings, depression, heart racing, bladder problems, and gut disturbances. So I do start low. I can always go upward. The biggest nightmare to a doctor who specializes in hormones is a patient who is overdosed. Getting the patient who's overdosed down is extremely difficult, as I'm trying to do with one of my patients now. And believe it or not, she's a physician, and she's overdosed. And the first thing I said to her is, please don't hate me. You're not going to like me when I bring you down off of these hormones. But it is about balance. We know what the perfect level is for every single patient.
We have two more small questions. What would you say the percentage of women who come in to see you actually need pharmaceutical therapy versus the non-pharmaceutical?
Oh, I see patients for everything in the world. So how much hormonal therapy did I do when I first started out? 100% of people came in looking for hormones. Now, because I do a very personalized medicine or precision medicine approach for everything that there is to do, so that it is customized, probably 65 to 70% of my patients come in looking for hormones. How many of them need them? It depends on the age of the patient. Certainly by the age of 60, most patients, male and female, need hormones. But again, if I have a young woman, she's on oral contraceptives, she may need testosterone due to the oral contraceptives. That doesn't mean oral contraceptives are problematic. What it means is if she's deficient, she'll get bone loss without that testosterone.
And then my last question is about education. So you went, above and beyond to get a better understanding of what you were working with and what you were prescribing. What would you recommend should be, do you recommend other prescribers get additional degrees in toxicology? Or what would be your recommendation for continued education in compounding?
Well, I agree with you. I probably went above and beyond.
Well,
okay.
Maybe not beyond.
But what I do recommend that anyone who prescribes hormones, they go back and they go to any course that's prescribed and run by a medical school. Certainly we run them at the Morsani College of Medicine. We are in relationship with Georgetown or George Washington University here in DC. They also run a course as well, and we commonly run it together. So I recommend that people take an actual course, whether it's one course or they get a certification or even a master's degree, and that it is associated with an actual medical school. And that way they will have a very conservative approach and have all the science-based therapy that they need to prescribe this perfectly for every patient.
So I had a follow-up to that related to clinical practice, given that you're at USF Morsani. So in your clinical practice, when you prescribe, are you electronically prescribing and the compounded BHT goes into the electronic record, and so is it an easily accessible database? And also claims data, whether or not there's insurance reimbursement and whether or not those that you're working with in other centers that have electronic records have access to that kind of data. Just, again, looking at how do we gauge the amount of use and the trends over time and what's in various formulations, and how do we garner more data on things like that?
Well, I'm happy to share my data with anybody that would like to look at it. Okay, we actually did a clinical trial where we looked at the 20,000 saliva test, and we used two different saliva testing companies that are actually competitors to see if this was reproducible information. It is, because we got the same results with two different saliva testing companies. I'm happy to share that data. I do have electronic medical records. I don't e-prescribe at this time, basically because it's so personalized, it's hard to do. I also like to have a relationship with my compounding pharmacist because they have a different knowledge base than I do, and I lovingly call that the triad: the patient, the practitioner, and the pharmacist. And in order for that patient to be really healthy, I can't tell you, my compounding pharmacist, and I use 23 different ones in my practice, okay? They're all PCAB accredited, but they're invaluable to myself and to my patient, because they learn different things than I do because they go to pharmacy school. They have taught me so much. Our patients teach us so much. It really is about the triad, and if we keep that in mind with the patient, the pharmacist, and the practitioner, that's how they get the best health care available.
So just to clarify, so I understand for the prescribing of compounded bioidentical hormones, you don't use the electronic record. When you prescribe other medications, do you post those into the electronic record, and this is separate from the electronic record, or do you not make any recording for any of the prescriptions that you do at all?
I record them in the chart. They're typed in. I don't e-prescribe because I actually like to talk to my pharmacist at CVS, Walgreens, Rite Aid, etc. I have a great relationship with them as well. You're supposed to have a great relationship. I have bad handwriting. I have a typical doctor's handwriting. I never write anything, so I either call it in. That's always the best way. From my pharmacist, I'm also getting information on how the patient is doing, whether, again, it's a traditional pharmacy or a compounding pharmacy.
Do you have a sense of whether or not there are other prescribers that are, in the field, likewise prescribing compounded bioidentical hormone therapy to patients that are utilizing and putting those into their electronic medical record system with the ability to track and to look at? I'm sort of looking at sources of data.
There's one electronic medical record system called Power to Practice that was designed to do that. We already had an EMR in our practice before P2P or Power to Practice came about, so we didn't change EMRs because it would have been cost prohibitive. We don't, the cost to our patients in our practice, almost everybody can afford what we're doing, even though we're offering a personalized approach. That's our goal in our practice, is that most people can have a precision medicine approach.
So just to understand, within at USF, within your setting, other practitioners that are prescribing medications post their medications into the electronic record system, but you don't. So you're allowed within your health system to prescribe without posting them into the electronic system. That's permissible.
Yeah, our electronic medical record system is different than the system at USF.
I see. So it's not a part of USF's clinical practice. That clarifies the question for me. I just wondered if the health system allowed you to have a carve out for the compounded bioidentical hormone. It sounds like no, it doesn't. Your practice is separate.
Probably cost prohibitive at this point, but if anybody who knows somebody who wants to help us with that, that would be great.
Got it. So that was one question. The other thing was about claims and whether or not there's insurance reimbursement for the therapies and the testing that patients have.
I think that you would have to ask the pharmacist if there's reimbursement. I will tell you that my personal health care, and I didn't go on Medicare when I turned 65 since I still work 80 hours a week. So I have a traditional insurance. My insurance does not pay for my hormones. Are my hormones cost prohibitive? No. I can't speak to the cost of other people, but my estrogen costs me $1.20 a day. My progesterone costs me $1.35 a day. So it's certainly not cost prohibitive for most people. When it comes to saliva testing, the test we use for patients that are new to our practice is covered by all insurances except for 4 in the United States with a small copay. The test we use for people once they're on hormones, I did what everybody else does in the world. I protect my patient. They don't take insurance, so I called up the saliva testing company and said, hey, I have all these patients I'm going to be using. Can you give me a better price for my patients? So they did. I'm there as my patient advocate. That's what I'm supposed to be there for. So I got them a lower price on their testing, so it wouldn't be cost prohibitive.
Yeah, Dr. Parker, let me just address a couple of those things. We actually do track in our EMR the medications, the compounded as well as the commercially based, but we also track the compounded hormones in the EMR. Moreover, we have a tracking program, one that we use that's proprietary to us, where we track the testosterone so that we know the lot numbers and who got those lot numbers. Those are readily available at an instant in time to print off the report, so we know the inventory. So which is compliant with what the DEA wants, because if the DEA comes in, they're going to count your pellets if you have pellets, and they want to know where the other pellets go, and we can tell you in an instant in time where those lot numbers are. So if someone's having an issue, we know where those lot numbers are. So we're very In terms of tracking, yes, we have that for sure in every one of our practices. Second of all, on the insurance side, insurances do pay for our consults. They pay for our lab work, both pre and post hormone therapy, so that gets covered in people who have insurance. We also have national contracts with all of the labs at a discounted rate, as Pamela said, for those patients who don't have insurance, so that it is reasonable. As well as insurance, some insurances pay and some don't in terms of the hormones. We've not typically gone to the insurance or third-party payers. I would love to go to the third-party payers and show them how much money I'm actually saving them, because they are coming off their antidepressants or sleeping pills or diet pills or memory pills. So I'm actually saving them money. But some pay and some don't. We've just chosen not to go that route so that we don't have to do pre-certification and all of those things, and the patients get what they need versus what the insurance company says they're going to pay for. And that's worked out pretty well. The patients are allowed to file for their hormones, and then oftentimes they'll get some money back for those. But I did want to tell you, we do track that.
One other question. How many various formulations does Biote have available?
Well, we have a ton. I mean, every patient could get different doses of testosterone, different doses of estradiol, different doses of thyroid. Not infinity, no.
So is there a number?
I don't know. From testosterone, we probably have 15 different. Estrogen, we probably have 8 to 10 different doses. And then thyroid, we have, again, probably 10 to 15 different doses.
From the perspective, if I could just address that for a second, when it comes to prescribing estrogens, the E2 and E3, it does matter the percentage also of whether E2 and E3 that you need. And we go by exact lab to determine that prescription and the percentage. So some patients I need 50% E2 and 50% E3. Some of my patients may need 70% E3 and 30% E2. So the percentages of the estrogen are also variable, and the same thing with thyroid. I mean, I can easily write a traditional thyroid prescription, which I do in many of my patients. But when you look at thyroid, there's levothyroxine or Synthroid, which is T4. A number of patients need T3, the other thyroid hormone. Some of the prescriptions, actually all of them, Armour Thyroid, Nature Thyroid, etc., are 4 parts T4 to 1 part T3. That particular ratio may not be perfect for every single patient. And so if they need a different ratio, maybe 1 to 1 or 20 to 1, then we have a compounded. The other reason I use compounded thyroid is there's an article in the medical literature suggesting people that have Hashimoto's thyroiditis should not get porcine thyroid. And that way I can have a compounded. It can be made non-porcine so that patients with Hashimoto's, which is an autoimmune disease, 70% of people with hypothyroidism, low thyroid function, have Hashimoto's, 70%. So a lot of my patients do need compounded thyroid, or they get Synthroid or levothyroxine made by a pharmaceutical company. I just go by the lab. Whatever the lab tells me to give, I give.
Can I ask a question, Don and Ruth?
Sure. Yeah, go ahead, and then Nancy, you'll follow. Thanks.
Okay, yeah. This should be pretty quick. Thank you both for your presentation and obviously your passion about your treatments. I did want to just to clarify one thing. I think you meant pregnenolone, not pregnenolone, because pregnenolone actually can't be metabolized to estrogen and testosterone. I'm assuming
I think it depends on what part of the country you're from.
Well, they're different compounds. Pregnenolone is the precursor of cortisol. Pregnenolone is a 5-alpha reduced and 3-alpha hydroxy steroid reduced compound, which is a neurosteroid, but it cannot be converted back to estrogen and testosterone. They're different compounds. But what I wanted to ask you is this: you said that you can get the perfect balance for everybody who comes in, which is wonderful. And I'm wondering, is that done empirically? That is to say, do you have an algorithm that allows you to look at all these different hormones and establish sort of exactly what the right ratios are, or do you use your clinical experience with this to sort of move things up and down, like you said, the percentages of E2 versus E3 and so forth? That's sort of what I'm curious how the laboratory tests relate to your clinical decision making.
That's a great question. Actually, that's the reason why we looked at 20,000 saliva tests to begin with. So we could develop an algorithm that we would have some place for the people who took courses on how to prescribe hormones to start, so that they know where to begin in 90 days. It's reevaluated and fine-tuned after that. But we do use the actual lab result as our guidance for it. And it's interesting. When you use the science, you discover that the symptoms are gone. I mean, for me, I'm all about the science. It starts there and ends there.
Thank you.
Yes. Do either of you work with the transgender community, especially adolescents?
I don't work with adolescents, but I do have transgender patients that are adults.
Yeah, we do too also.
So in terms of pediatric dosing, that wouldn't ever be an issue. Is there such a thing as pediatric dosing for bioidentical compounded?
I've had patients who were adolescent that went through transgender, but we don't do it, and we don't train to it either. So it's just not my area of expertise.
So for those adults seeking compounded bioidentical hormones, how would that differ from treatment with FDA-approved bioidentical?
That's a great question. I have been spoiled. Most of the time, I teach at the Morrisani College of Medicine. My personal practice is in Michigan. So if you ask me where I live, I will tell you Delta Airlines. Okay? Because I go back and forth and back and forth and back and forth. I honestly have 2 million miles. Okay? But I was spoiled. Wayne State University had one of the largest, transgender communities, and that doc retired. And then some of the patients found us, and I'm very honest with them, because I wasn't used to treating transgender patients because the world expert was down the street. We now have a number of them, and we're working with them to try and develop norms, because the doctor who treated them actually didn't measure hormones. And we don't know what the norms are. I look forward to come back and tell this committee basically what we're finding, because we're measuring every single one of them over and over again to try and find the perfect balance for them and not increase their risk of disease.
But how would the use of compounded bioidentical hormones differ? Because I think especially Dr. Smith said that you also use FDA-approved bioidenticals. Would there be a difference? Would there be?
It would just usually be in the difference in dosage and what you would need. I mean, if you're looking at, because we look at many things. What determines the dosage is weight. What determines is most of the hormones are cleared to the liver. What is the actual liver function of the patient? What is the age of the patient? Most patients, as they age, need less hormone. We use many different things to find out what is the perfect dose. But again, we may not be exactly correct the first time. It takes 90 days for those hormones that are natural to get off the receptor sites. It takes 6 months for synthetic hormones to get off the receptor sites. So we remeasure in 90 days and fine-tune it over and over again.
Hang on one second, because we're sort of approaching our limit here, and I want to make sure the specific questions of the committee come forward. Adele, I think you had a question as well, Nancy, but I think you may have one that didn't answer. So we want to wrap it up so we can take a short break before the last panel. But
Dr. Smith, you're aware that FDA guidance on measuring testosterone requires measuring testosterone in plasma, total testosterone in plasma. Can you comment on the correlation between saliva, testosterone, and plasma?
Well, the actual FDA requirement now is to look at both the bioavailable and look at the total testosterone as well, meaning the free testosterone. So all labs now do both. And so if I'm going to do serum testing, I would be both. To answer your question on saliva testing, if you're measuring the bioavailable, it depends on how the person is receiving the testosterone. If the patient is giving the testosterone transdermally, then it's not going to show up in the serum. That study was done by us, and we're about to publish that trial. So we know it doesn't show if it's put on transdermally. If you're using IM, it does show up in serum, and it correlates with what we see in saliva testing if it's used IM.
But there is data that shows lack of correlation between saliva and plasma.
It depends again on your mode of application. There is lack of correlation if you're putting it. If you're putting it on transdermally, it's not the same. So that's the reason we did our clinical trial. And the reason we did our trial is that, remember, men only make 4 to 8 milligrams of testosterone a day. Studies are done showing that if you put on transdermally, 71% gets easily absorbed. So why would we give someone 200 milligrams of testosterone just to keep increasing the dosage to satisfy a blood work study? And that's the reason we did our actual trial looking at transdermally applied. Again, it's different if it's IM. If you're giving it IM, then it does show up in the serum.
So the issue here is the standardization. When you say a compounded product, you know, that there is no unique formulation for that. You know, there is, pharmacist has the ability to, other than the active ingredient, other ingredients that included the excipients primarily change. So in other words, I know you said you have good relationship with your compounding pharmacist in the area, but would you recommend that in other areas, women who are considering this, they can just get from another pharmacy that may not use the same type of compounding procedures that are used in a particular pharmacy? The lack of a unique product, when you say compounded, we're not referring to a unique product, but a multitude of product. It may include the active ingredient, but in addition to that, it can include excipients that affect the ultimate bioavailability. You're measuring one data point, right?
No, I'm not. I'm actually not, and that's an actual question. That's fabulous to ask, so thank you for asking that, because I did not address that. When I'm looking at female hormones, I don't look at one data point, because in younger women, it changes. So we actually look at a 30-day supply. So we're looking at data points on 11 days over 30 to see where her hormones actually stand. So no, we're not looking at one data point.
And then beyond that, what happens?
And beyond that, if in younger women, we may look at 1 day after we've looked at a 30-day to see where they stand. Is there a change in bioavailability? Of course.
Yeah, that's what I'm getting at. I mean, bioavailability, definition-wise, I need to get over, a dosing interval period.
That's the reason why we do longer testing. Yeah. I totally agree with you, sir.
Yeah. So from there, and going to also this precision medicine theme that's been talked about, why don't we then do the trials and empower them to see an effect?
Well, we are going to publish our trial that we did. The biggest issue has to do with funding. And I think that's the true, no matter who's doing the trial. And I'm very blessed that one of my patients is very wealthy, and he actually funded the trial for us. So he just wanted to know himself, because a lot of his friends said, well, it doesn't matter anything about all of this. And so he actually funded our trial at looking at 20,000 tests.
Great. Well, thank you both very much. We're going to take a how many minute break here?